Hello and welcome to my Opthal teacher, and we're going to talk about conjunctival degenerations and tumors today. There are two main types of degenerations, that is pinguicula and pterygium. So looking at the pinguicula, it's a triangular patch of hyaline infiltration, as you can see here, and it is slightly yellowish in color. The word pinguis means fat. So it is basically fatty tissue. Features, it is seen in older age and those exposed to strong sunlight, dust and wind. Usually occurs near the limbus, more commonly nasally, and it is very conspicuous when the eye is inflamed. For example, when this is a nodule, and when it gets inflamed, it can be confused with a nodular episcleritis or a nodular scleritis or flictanular conjunctivitis and so on. It requires no excision as such. Then we come to pterygium. A pterygium is basically an advanced form of a pinguicula where there is a triangular encroachment of vascularized granulation tissue covered by conjunctiva in the interpalpebral area. For example, here, this is a pterygium. Okay, also this one. So, the pathology here is that now this is a histological section of the pterygium. This is the epithelium over here, and basically there is fatty infiltration and granulation tissue in the subepithelial part. Now, this granulation tissue, along with covered with the conjunctival epithelium, it grows on the cornea like this. Okay, like this. So this is the leading edge of the pterygium. Now it has three parts. It has a cap. This part is the cap. It has a head. This is the head of the pterygium. There is a neck, okay, and then there is a body. Again, the same things over here. Now look at this. This is basically a pseudopterygium or a symblepharon, right? This one. A symblepharon is basically formed post chemical injury and it has to be differentiated from the pterygium by the probe test, which we'll be discussing in the subsequent slides. So this one's the histology. This is the cap, head, body, and stalker line. Stalker line is a favorite MCQ. It comes as a one-liner. Stalker line is basically one of the corneal lines, so-called lines. There are several corneal lines. So stalker line is a line of iron deposition at the leading edge of the pterygium. You must know that. This one's an inflamed pterygium, and this is pseudopterygium secondary to a chemical burn, right? What happens here is that this is cicatrizal conjunctival inflammatory overgrowth. Okay, cicatrizal conjunctival inflammatory overgrowth. Whereas here there is no inflammation, it is just granulation tissue covered by conjunctiva that is encroaching the cornea. Clinical features: bilateral nasal vision is impaired if the pterygium is big enough to invade the cornea or it is invading the visual axis. It is thick and vascular in early stages but becomes thin, pale, and atrophic later. So, differential diagnosis: pseudopterygium. We saw a picture of pseudopterygium. It forms post-trauma chemical burns or chronic conjunctivitis. How do you differentiate? A pseudopterygium is formed and it stays that way. It is non-progressive. It is not necessarily in the nasal or temporal, unlike a pterygium. It can be present superior and inferior also. Adhesions to the lid and the underlying surface, unlike a true pterygium, right? So basically, in a true pterygium, you can pass a glass probe below the body of the pterygium, right? Because it is not tightly adhered. Whereas in a pseudopterygium is a solid fibrotic mass. Tight adhesions are there to the lid and the underlying surface such that you cannot pass a probe below it. So that's the difference. Then indications of surgery of a now see, this is a symblepharon. It is a pseudopterygium, right? You cannot pass a probe underneath it. Whereas in case of a pterygium, you can pass a glass probe underneath it. Indications of surgery: if the pterygium is progressing in the pupillary area, causing excessive astigmatism because it is on the cornea, so it's going to change the curvature of the cornea. Restriction of ocular motility. How? Usually, sometimes a nasal pterygium, a thick, bulky nasal pterygium can, even invade the medial rectus muscle over here, and then it can cause motility issues. And of course, disfiguring. So, steps of pterygium excision. Now, this is the medial side. So this is a nasal pterygium, right eye. Okay. So just go through the steps with me. Hold the neck near with the fixation forceps. This is the neck. We hold it with the fixation forceps. We raise it, dissect it from the cornea, right? We've held it over here and we start dissecting from the cornea. We go up to half the distance towards the canthus, up till here. Okay. Now you have to be very careful because there is a medial rectus muscle over there, so you cannot cut that muscle. Once the body of the pterygium is completely free, you excise the head. This part has to be excised, okay? This part on the cornea has to be excised, and you have to do a superficial keratectomy with the help of a crescent blade to clear off that cornea. A bare area of sclera remains at the edge of the cornea here, okay? The cornea is now cleared. The head of the pterygium is cut off. We were holding it at the neck, so some part of bare sclera is going to remain here. And what to do with this bare sclera? This bare sclera in the usually when the grafting was not done, bare sclera was just left as it is. But then it leads to a lot of recurrences. So it is better if the sclera is covered with the autograft taken from the same eye conjunctiva from the superotemporal quadrant, or an amniotic membrane can be put. So basically, it is better to cover this bare sclera, right? And then we put small sutures, vicral sutures, which get absorbed. That's the steps. The third type of conjunctival degeneration is concretions, which are minute, hard yellow spots. Now, as the name suggests, concretions, they're not actually calcium, but they are inspissated mucus in depressions known as Henle glands, which are present in the normal conjunctiva. Okay, Henle glands. So mucus gets accumulated and inspissated such that it becomes hard, stone-like, and it becomes a concretion. So see, sometimes a concretion can be big enough, so big that it can cause corneal erosions. Okay. So the features are foreign body sensation, corneal abrasions, and they are of course very common. If they are causing symptoms, they can be removed with a sharp needle, such as a 26 gauge needle, else not needed. Conjunctival calluses. Now, this may be seen in older people, especially. So, basically, this is a fold of redundant or extra conjunctiva interposed between the globe and the lower eyelid. Okay, so this is excessive conjunctiva that is sort of overhanging. It's a normal aging change, and it may be exacerbated by inflammation and mechanical stress related to dry eye and lid margin disease, right? So, that's the redundant conjunctiva over there. Now coming on to conjunctival cysts and tumors. We've seen four degenerations: pinguicula, pterygium, concretions, and conjunctival calluses. Now moving on to cysts and tumors. So cysts can be of these types. It can be a retention cyst or epithelial inclusion cyst, which can be formed post trauma or post, any ocular surface surgery. Lymphangiectasia, sometimes with blood. For example, here. So lymphangiectasia are dilated lymphatics, which are transparent. If filled with blood, they can look like this. Subconjunctival hydatid cyst and cysticercus are relatively rare. So let's move on to tumors. Okay. Now, congenital tumors are also known as choristoma. I hope you know the difference between a choristoma and a hamartoma. So this one, the one on the right, is the dermoid. Okay. Dermoid are lenticular yellow tumors usually seen at the outer limbus. Now see, it looks like a lentil, and it has a typical stuck-on appearance at the limbus. What does it consist of? Epidermoid epithelium. Epidermoid epithelium means skin-like epithelium. That is sebaceous glands and hair, which are not a component of the normal conjunctiva. It tends to grow at puberty. Removal, if now see, anything that is encroaching the cornea can cause astigmatism, or it can even invade the visual axis over here, leading to decrease in the visual acuity. Then it has to be removed. How is it removed? By a keratectomy, a superficial keratectomy. Now this is deeper than a pterygium, okay, and it is a solid mass of a choristoma. After removal, a scar remains, so you have to tell the patient preoperatively, and a lamellar keratoplasty may be required. If too much of the cornea is removed while removing the tumor, then it has to be replaced with a lamellar keratoplasty. So this one's a dermoid present at the outer limbus and it has a lenticular stuck-on appearance. Now this one is a dermolipoma. Okay. Now this is a fibrofatty tumor and found at the outer canthus. So it is soft fibrofatty tumor, fibrous plus fatty tissue, sometimes with dermoid tissue on the surface. So you might see hair and fat, etc. over here. Now, I don't know if you can see, but I've just highlighted the fatty part. It looks slightly yellowish in color. Then this is not encapsulated, and this may be removed with care if cosmetically unacceptable. Always remember to differentiate dermolipoma from normal orbital fat prolapse, which is seen in older people. So you have to always compare the two sides, ask the patient to look down, notice the superolateral quadrant of the globe and see whether it is the same on both the sides, right? So you have to differentiate it from orbital fat. Dermoid and dermolipomas are commonly seen in the golden heart syndrome. Coming on to papilloma. Now see, this is a papilloma. Okay. Again, they are associated with HPV 6 and 11. Papillomas, histologically, they have a fibrovascular core covered by non-keratinized stratified squamous epithelium containing goblet cells, right? So this is the non-keratinized squamous epithelium containing goblet cells. The white structures that you see, those are the goblet cells. And there is a fibrovascular core. So it's just like a wart. So this is a conjunctival wart, okay? The treatment is excision, cryotherapy. These are various treatment options. One can use any. And if there are recurrences, subjects, there are drugs, subconjunctival interferon alpha, carbon dioxide laser vaporization, mitomycin C, oral cimetidine. Look at this. Again, this is a wart. And this is a lot of papillomas, right? So associated with the HPV virus, and it has to be, although it is benign in nature, it has to undergo a complete excision so as to rule out a squamous cell carcinoma. Then we come to granuloma. So a simple granuloma is basically nothing but granulation tissue which is polypoid in nature. See, it's polyp-like. It is seen in peritomy wounds, sites of foreign bodies, empty sockets after excision, and site of chalasia which have been insufficiently scraped. So maybe, such as in this picture, they may have been a pterygium, right? So post healing of the pterygium excision, exuberant granulation tissue is being formed. So this is a simple granuloma. Then sometimes the granuloma can become pyogenic. There can be pus formation in the granuloma. So it's the same thing except that there is pus in it. Treatment is an excisional biopsy. Now, even the lesions that I showed, that huge warts that I showed you, even they require an excisional biopsy. You have to rule out cancer in these cases. You have to rule out malignancy. You cannot rule it out with the naked eye. You can only get a provisional diagnosis or a list of differential diagnosis for such conditions. The treatment is excisional biopsy only. For example, this structure. Now, this is a squamous cell carcinoma, right? But then it looks like a wart only. These also look like warts, even though, albeit it will be more aggressive. So how will you differentiate? You can only differentiate it from a biopsy or a histological section of it. So squamous cell carcinoma location usually at transition zones such as the limbus. So they are commonly seen at the limbus. Malignant potential is there. It includes Bowen intraepithelial cancers also. It spreads over the surface and into the fornices, but it does not have a vertical penetration into the globe. Treatment is wide excision. You have to take 2 mm, 3 mm margins from the tumor, margins of normal tissue from the tumor, and you have to do diathermy or cryotherapy to the base to avoid recurrences. And you have to send the tissue for microscopy. For recurrences, orbital exenteration and radiation therapy because it can metastasize. Topical chemotherapy consists of these agents. Now you have to know about this term, ocular surface squamous neoplasia. This is a new terminology, okay? It describes a spectrum of slowly progressive benign, premalignant and malignant epithelial lesions of the conjunctiva and the cornea. So remember all of these lesions, even the papilloma that I showed you, they now are encompassed in an umbrella term which is known as OSSN or ocular surface squamous neoplasia. Okay, so this picture over here, this is showing intraepithelial neoplasia. This is just the epithelium, and you can see that the normal stratified structure is lost. And in this case, basically, you cannot really differentiate between the epithelial and the subepithelial tissue. So the entire structure is disrupted. So this is not in situ anymore. This has actually invaded and become a carcinoma. And this one is a carcinoma in situ. Lymphomas, they usually occur on the bulbar conjunctiva or the fornix. They are painless, slow-growing, salmon-colored masses. Okay, and whenever you see a lymphoma, you have to rule out a systemic malignancy such as leukemias and non-Hodgkin or Hodgkin lymphomas. Also, you must do a systemic evaluation. Radiotherapy, now lymphomas are quite amenable to radiotherapy. Okay. Also, you have to rule out amyloidosis. Okay. Even amyloidosis can have this appearance. See, this one is amyloidosis. So how will you rule out? You can only rule out by an excisional biopsy. Kaposi sarcoma, seen in patients with HIV/AIDS, eye involvement can be the first manifestation. Lesion may also affect the skin of the eyelids and the face. It is a highly malignant tumor, okay, and sometimes it can be mistaken with a severe type of subconjunctival hemorrhage. Not this one, of course. This one looks very much malignant. and the treatment is palliative with radiotherapy. And early Kaposi sarcoma can look like a severe subconjunctival hemorrhage. Now we'll talk about the pigmented tumors. Pigmented tumors are clinically difficult to distinguish, okay? So they are divided into three categories: non-cancerous, potentially precancerous, and frankly malignant. Non-cancerous includes a simple nevus, for example, this one, and epithelial melanosis like this one. Potentially precancerous and malignant lesions, we'll be looking at the subsequent slides. So nevi, they are seen commonly in a lot of patients, and these are pigmented macules or nodules at the limbus or near the plica. This one, see? They're usually congenital, they tend to grow at puberty, and they are rarely malignant. Okay, so they just remain as they are since birth. They might grow a little at the time of puberty, but that's it. Then precancerous melanosis. This is a diffusely spreading pigmentation of the conjunctiva. Now, you cannot differentiate it from a normal melanosis, but then there are certain signs and symptoms, there are certain features which can tell you that a lesion is malignant. Okay, I'll be discussing in the next few slides. So, this, you see, look at this. This is an atypical type of pigmentation. It is not looking like a nevus or a normal conjunctival pigmentation, right? It is present on the lid margins, it is present on the palpebrum, it is extensive. So this thing is seen in the elderly. It spreads slowly. It may or may not become malignant. And if detected early, it is radiosensitive. Later on, it goes on to become radioresistant. Lastly, malignant melanoma. Now, this is a malignant pigmented tumor of the conjunctiva. It is rare, occurs typically at the limbus, usually pigmented, seen mostly in elderly, so you will see it in older age group. It can arise de novo or from a pre-existing nevus or melanosis. Elevated, highly vascular tumor which spreads over the surface of the globe but rarely penetrates it. Recurrences mets are common. Treatment is by excision of the globe. Why? Because this is a highly malignant tumor or exenteration of the orbit. Remember the ABCDE of melanoma, or ABCDE is the mnemonic to rule out malignant tumors. Asymmetry means the it is asymmetrical. It is not a well-defined circle or a nodule or anything. It is an irregular shape. Border. Borders are poorly defined. Like, look at this. The borders are poorly defined. Now, this one is well defined. You look at other criteria also. Color. It has a variegated appearance. There is white, there is black, brown. So this is not normal. Change in color is not normal. Diameter, increase in size of the nodule is not normal. Evolving, evolution. For example, changes. Evolution means changes in color or size. And look at this tumor. This has feeder vessels also. So this is likely to be a malignant. The final diagnosis rests upon an excisional biopsy, right? So I'm going to upload the presentation on my YouTube channel, and thank you for listening.